Welcome. My name is Hugh Brewster. I'm in Toronto, Canada. I'm here on behalf of the Circle of Cleft Professionals, and I'll just pass it over to my colleague Neeti to get us started today.
Hello, everyone. I'm Neeti Daftari, here on behalf of the Circle of Cleft Professionals. Welcome to our 24th webinar. We have Dr. Barbara Delage here with us today, joining in from London to share some research insights and best practices on measuring and advancing nutrition in patients with cleft. So to make the most of this webinar experience, I'm going to request you to please display your full name on the screen to make it easier for everyone here to interact and respond to each other. If you would like to change your display name, you could just click on the participants button below and then click on rename. As you mentioned, you could also use the Zoom chat to let us know your name and where you're from. While the presentation is on, while Barbara's presentation is on, we request you to please mute yourselves to avoid and prevent any background noise. Zoom also has these reaction buttons located at the bottom of your screen. So feel free to use those reaction buttons as well as the chat feature to share with us what you're thinking or feeling, or if you have any questions that you would like to ask us at any point during the course of this webinar. After Barbara's presentation is done, we'll invite you to ask questions, which you can do either via chat or by video after unmuting your microphone. As always, we'll begin with a short CoCP update, which will be followed by Barbara's presentation, which will last for about 25 minutes, which is then followed by questions and discussion for the remaining half hour. So overall, this webinar is planned to run for an hour. We have three core objectives on the CoCP. Our aim is to facilitate networking and collaboration amongst cleft professionals with an interest in comprehensive cleft care in LMIC context, to communicate the learning and impact that's been happening in cleft care that will in turn support the growth of local teams in implementing comprehensive care. We're growing as a community. We now have 440 members belonging to 12 plus specialties within cleft care, who have joined us from 65 different countries across 6 continents. These are the 65 countries that all of our members come from, the ones in green being the ones which have the largest membership. Finally, the CoCP is made possible thanks to these 10 international charity organizations who believe in comprehensive cleft care in low and middle income countries. So over to you, Hugh, to take over from me.
Great, thank you. So to get started, I think if you log in early, you'll hear that this is a pressing topic on a variety of fronts. One is to do with the pandemic that's ongoing, and definitely we've heard already, this is seems to be another wave in many countries. It's a difficult time. We're glad that you're here. We recognize this is a very difficult moment for many of us, and we're delighted that you're able to share and hopefully to draw some encouragement from this community of worldwide cleft professionals. And the second thing is obviously the connection between the COVID pandemic and food insecurity or malnutrition. So we'll launch a quick poll if you're able to, and it might be a little bit more tricky if you're following on a phone of some sort, but if you're on a computer, Neeti will launch a quick poll to see how are we feeling about these topics today. So go ahead, Neeti, we'll see how this goes. So the first question, how concerned are you about the impact of the pandemic on cleft care in your context right now? From all the way from not at all concerned to extremely concerned. And then the second, you're on the call today, but for you, how much of a barrier is food insecurity or malnutrition to those most vulnerable families that you're supporting? And we'll just give you a second to respond to that survey, and we'll share the results in a second. I see the results coming in. Well done, everybody. I'll give you another 10 seconds just to consider your choices. If you're able to respond to the box on the screen, that'd be very helpful. All right, 3, 2, 1. All right, we'll end this polling and we can share the results. So you see, very concerned by far. The pandemic is something that is on our minds and is definitely impacting our work. And then we see that, you know, everyone on this call is facing it as a barrier, especially for those most vulnerable. So always a barrier, a frequent barrier, and then definitely an occasional barrier. So we're here that this topic obviously is very close to what we're thinking about in terms of our work with cleft care. Barbara, this is a great introduction to to what's going on. If we go to the next slide, you'll see the group is primed and ready to hear a little bit more about what you've been working on in your role with Smile Train. If we can go to the next slide. Thank you. So we're delighted to have Dr. Barbara Delage from Smile Train. She's based in the UK, and her background definitely is in nutrition. She has a PhD, and she's officially Smile Train's nutrition advisor. And really thinking about this topic, right? What are the adverse outcomes of malnutrition in patients, and how do we overcome them? So Barbara, thank you for joining us today. We'll hand the floor over to you. We'll do this bit of technical magic where we stop sharing, you start sharing. We see how this all works. We're all crossing our fingers. We have this 24 times, so it's getting a little easier. But we're really delighted to have you join us today. And it's working. I think we got it. All right, so over to you. We'll listen, and definitely along the way, if you want to use your reaction button or use the chat, we can continue that conversation. Don't let it distract you. And then we'll pick up some of those threads and hopefully have a fulsome discussion in about 25 minutes.
So hi, everyone. Thank you for having me in this CoCP webinar series. So what I plan to cover today is summarized in this first slide. I will start from what I think you are all familiar with, that is the feeding difficulties experienced by the children. And I'll highlight some of the main barriers to nutrition care provision, discuss some of the implications, and share with you some data that we have on the burden of malnutrition in this population. And finally, discuss opportunities to improve the provision of care to these children. So why are children with cleft more likely to experience feeding difficulties? Well, the whole system of feeding and swallowing depends on the anatomy of the mouth, but in otherwise healthy babies with cleft, swallowing is usually not an issue, but sucking can be challenging. And normal sucking requires the building of negative pressure inside the mouth, which is possible if there is a tight seal of the lips around the nipple, and if the nasopharynx is close by an elevation of the soft palate. And then the infants, they rely on their tongue to press the nipple against the hard palate and to strip the milk from the breast. And depending on its size and shape, a cleft can prevent or limit suction. However, usually this is more of a problem with the cleft of the palate, in particular if complete, with some small adjustment. Babies with isolated cleft of the lip should be able to breastfeed. For children with a cleft of the palate, breastfeeding can also be successful when the cleft is narrow and posterior, but really the severity of feeding difficulties depends on how limited their capacity to suck is. So other issues that are mentioned in this list, besides insufficient suction, include excessive air intake, choking, nasal regurgitation, fatigue, excessive time required to feed, and associated with these, inadequate milk intake and failure to gain weight. So when a child has difficulty sucking, tires easily, swallows too much air, he will feed primarily on the formilk. He will never empty the breast. He will never reach the milk at the end of the feeding that is high in energy and that would support weight gain. So why do these children fall through the cracks of traditional nutrition programs? Well, there are many barriers to feeding and nutrition care provision. Local beliefs about what causes cleft are one of the main barriers to care. And this goes with the lack of awareness and knowledge by communities, but even by healthcare workers sometimes, that this is a treatable condition. As an example, one Smile Train partner recently in rural Kenya And operated a 24-year-old young man with an isolated cleft of the lip. And in fact, what happened is that when he turned 24, his uncle bought him a smartphone, and for the first time he joined social media. And that's how he discovered that he was not the only one with a cleft, and that this was something that could be fixed. And that's also how he reached out to our partner in this setting. So the lack of awareness remains a major barrier to care in many settings. Besides, even local programs that focus their work in preventing and correcting malnutrition do not understand cleft. And they might dismiss children with cleft, considering that they should be taken care of by cleft providers. And therefore, they are missing the opportunity to provide timely support. Other barriers to the provision of feeding and nutrition care by cleft care teams is the lack of resources and the lack of training in feeding, counseling, and nutrition. So from the time of birth, and as for any other infants, ensuring adequate nutrition is the first priority for infants with cleft, and supporting the mother in overcoming difficulties is key. Of course, like I said, newborns vary in their ability to cope with the cleft, but we know that with feeding counseling, by making some adjustment, we can go a long way into helping the infant who has difficulties in obtaining adequate nutrition. In limited resource settings, these adjustments ought to focus on breastfeeding, or at least on the initiation of the production of breast milk and the maintenance of this breast milk production, so that the mother can feed her infant with breast milk. In limited resource settings, again, regardless of whether a baby has a cleft, non-breastfed infants are up to 25 times more likely to die of diarrhea than breastfed infants. Another issue is that complementary foods and liquids other than milk are often introduced much earlier than recommended by optimal feeding guidelines, and these inappropriate IYCF practices also pose a significant threat to the health and the survival of these children. There are many more reasons not related with the anatomy, in particular some false beliefs about what a cleft is about, that prevent the children from obtaining adequate nutrition from the time of birth. And that is why feeding counseling is the right time to dispel these beliefs. So providing feeding assistance as early as possible after birth is key. And although I'm not taking the time to go through growth monitoring, this is also essential. And because really when this timeline is not met, when resources are not in place to ensure early feeding assistance, the consequences are many. Of course, poor growth and malnutrition, they may delay surgery, they may interfere with the development of the face, the development of the dentition, of speech. They may have an impact on hearing and feeding capabilities, and of course, negatively impact the psychosocial well-being of the individual. But really, regardless of the presence of a cleft, undernutrition before age 2 causes irreversible damage that compromises the future of these children. And this is the reason why the priority should be on preventing malnutrition and not just on attempting to mitigate the damage. So I'm showing you a figure that is actually pretty old. It comes from the 2008 Lancet series on malnutrition. And what it shows is the irreversible damage caused by stunting and wasting, which is the risk of mortality that is increased in children who are wasted and stunted. Wasting in children correspond to having a low weight for length or height, and this multiplies the risk of premature death by 10. Stenting, that correspond to having a low length for age, multiplies the risk of dying by 4. But besides increasing the risk of mortality, wasting and stenting have long-lasting consequences. For a child to be stented, it's not just about having shorter bones. It's also about having smaller organs, including the brain. These children, they have a weakened immune system. They are at higher risk all their life of infection and illnesses, of obesity and chronic disease. And they are at high risk of long-term damage on intellectual and cognitive functioning. They are more likely to experience psychosocial difficulties, behavioral difficulties, to perform less well at school, and to overall fail to fulfill their potential. So we attempted to estimate the scale of malnutrition using data reported by SMITRA and partners globally. So the analysis, we did that in 2018, and we included over 600,000 primary surgeries in children 5 years and younger at the time of surgery. And what we found is that about 30% of the children undergoing surgery were underweight. Note that this occurred despite SMITRA's policy on minimum weight for age at time of surgery and despite the availability of grant resources to support feeding and nutrition. But again, I'm happy to discuss these results after my presentation. We also analyzed the data by countries. Here I show you the data from children operated in the African region. And what we did is compare the prevalence of underweight among children with cleft for given countries. So these are the blue dots, to the prevalence of underweight in the same countries, but in children without cleft. And these are the orange dots. So for national data on underweight prevalence, we made use of publicly available data from the DHS program. There is a link here, and the date under the orange dot correspond to the latest survey. So what we observed is that for most settings, failure to thrive was pretty much systematically more prevalent in children with a cleft than in their peers without a cleft. So we put together this data in a paper that we are trying to publish, and it has been really a call to action for SMITRA to grow and invest in nutrition program in the last few years. And this is what I'm going to discuss now. There are opportunities for improving feeding and nutrition care provision for patients with cleft, especially if there is a collaborative effort from all stakeholders to promote inclusiveness and to undertake practical steps to improve the way these children are seen and cared for. Some of the priority areas that can lead to measurable improvement in the feeding and nutrition care of these patients are listed here. They include early identification and referral, timely and effective feeding assistance to mothers to overcome feeding difficulties and ensure adequate nutrition to the children, early identification of patients at risk of malnutrition or already malnourished, and for cleft teams, it has to be done from the time of first presentation, and provision of appropriate nutrition care and appropriate management for children at risk or already identified as being malnourished. So one of the steps SMITRA has taken is to reach out and engage with organizations like the Speak Nutrition Society, which is the Kenyan Association of Nutritionists, to educate them about cleft and about the essential role they ought to play in early feeding assistance, in nutrition support to mothers and children, and in referral. Another example is the formal partnership that SmileTrain has established with the OB-GYN Association in India, again, to raise awareness, to educate these professionals about early diagnosis, feeding counseling, and referral to cleft providers. To address some of the priority areas that I mentioned earlier, I thought I would highlight one of the resources we developed with the objective of educating and guiding partners' efforts towards offering and improving feeding support and nutrition care to patients. It's a guidance in nutrition care provision document that defines and describes minimum standards of care regarding the three components of nutrition care provision: feeding counseling, nutrition assessment, and nutrition care. These documents actually describe the key nutrition care actions associated with each nutrition care components, as well as the professional competencies required to undertake these actions and ensure that the most effective, appropriate, and safe care is provided to all patients in need who are managed by SmileTrain partners. So we hope really that this document can be of help to our cleft partners who want to maybe audit their current activities and human resources in relation to feeding and nutrition care, and also those who need to start a nutrition program or need to improve the quality of their current activities. You may have heard that there was a nutrition training curriculum that was developed with SmileTrain together with the Spoon Foundation, again, with the objective to improve partners' capacity to provide feeding and nutrition care to patients with cleft. The building of capacity in cleft teams is done through improving the knowledge and skills regarding the feeding counseling of mothers and their infants, and also by teaching them best practices when it comes to IYCF and nutrition assessments, such that partners can be well equipped to address the feeding and nutrition challenges faced by the patients and their carers, but also become able to identify when something might get wrong or is already getting wrong. Sorry. So this is just the table of contents. The training curriculum cover 9 lessons and 37 topics. The training package includes a trainer's manual that describes the learning goals, hands-on activities, and all the information that needs to be taught by the trainer. It goes with a PowerPoint presentations, and the training package also includes material for hands-on activities and hands-out for participants. And the training is organized around pre- and post-test to assess participants' learning. So referring back to the nutrition care components, of course, nutrition specialists have the knowledge, the professional competencies, and the experience to deliver all these components. But for cleft providers who do not have a nutritionist involved in the care of their patients, or who need to support the care of a nutrition specialist who is not always here to review their patients, the nutrition training can help with shifting some of the activities, in particular those activities related to feeding, counseling, and nutrition assessment, into the hands of other healthcare workers who are not nutrition specialists in the first place. So I'm finishing by mentioning the SmileTrain Nutrition Grant, which is also meant to address some of the barriers to care by helping partners start a nutrition program and expand and strengthen their existing program. all the nutrition-related activities described in the guidance for nutrition care provision document can be potentially covered by this nutrition grant. Any partner who has identified needs and who would need help to support feeding and nutrition activities to cover those needs can apply. And if granted funding, grantees are asked to track their the patient they support and actually to report their successes and their remaining challenges in an annual report. So that's all what I wanted to highlight, but now I'm happy to hear your thoughts and take any questions. Thank you very much.
Thank you, Barbara. That was very informative and a great start, I think, a foundation for our discussion today. So as usual, if this is your first Circle of Cleft Professionals webinar, then we do move now into a time to really unpack what have we heard? How does it apply to your own context? What are your questions for Barbara or for the group about how you're managing this situation? And again, with the context that we heard from the very top, that we know that vulnerable families are facing increased food insecurity during this time of disruption in COVID-19. So we know this is something that's very close to the practice of our teams in resource constrained settings. So feel free to use the chat if you want to ask a question that way. If you're able to put your camera on and want to ask a question that way, I see one hand up, and so I will acknowledge those as well. So there's lots of different ways to get in touch. But Krishnamurthy from India, please start off. Let us know.
Right. So Barbara, that was a nice presentation. I just have a couple of things to ask you regarding breastfeeding. We have always been unsuccessful training mothers to breastfeed, and because for some reason, it's as you already mentioned, it's quite ineffective, and we end up asking them to express breast milk. Now, we've always gone for a manual method of expressing breast milk. Does it make a big difference if we use a breast pump as opposed to manual breastfeeding? Because that is the impression I get, because with manual breastfeeding, it tends to dry off very fast.
Okay. First, I need to say I'm not a specialist on that matter, but what I can say is that other partners, they will use a manual pump or an electric pump, especially for mothers who are, really in a vulnerable situation. For the others, they will go with manual breastfeeding and successfully. So I think it's really, there's not one solution that fits all, right? And it really depends on the mothers. So that's really what I would say. After that, I mean, sincerely, I would imagine that for some mothers, maybe, manual, I mean, depending again of their situation, if they have other children to take care of, etc., maybe using a pump will be, a manual pump even, will be more conducive for them to continue breastfeeding, because really what's important is for them to breastfeed for at least 6 months, if not 2 years. So, yeah.
Thank you.
And if I could join in, I'm sorry,
Please,
I just want to make a point. Hi, everybody. I'm Pam Sheeran from Small Train. I just want to thank you, Barbara, for that presentation. And hi, Dr. Krishnamurthy. I just want to put out there that this is a concern I've heard often from our partners throughout the Americas. And we actually are working on, for our grant program that Barbara mentioned, applying for a hospital grade pump that's safe for sharing across mothers is something that you can apply for in the grant, and also just having a supply of manual pumps to be able to provide for those that need it to take home. So it's something that you can actually ask for support, but it's those they can be expensive, and it's how many mothers are you seeing, how sustainable is that to be able to give each one. So that's where, some mothers just really trying to support them to see if they can try and breastfeed on the non-cleft side, for example, or express into other items like a cup I know there's innovations around the type of Nifty cup, which is something maybe some of you have heard about, and Sponsoring's also trying to look into supporting our partners to have better access to be able to help them express and then immediately give to the child.
Thanks,
So
Pam.
that is something that we definitely hear often, and I'm sure many of you on the call too.
Great, very helpful. And I do notice, Barbara, in the curriculum, that is where some of the curriculum starts is really that importance of breast milk. So thank you, Dr. Krishnamurthy. That's a great start. In the chat, we also have some specific questions, really on this idea of assessing weight. So we know that ID and referral and that tracking, Barbara, is one of the top 4 things that you focused on in your presentation. How do you go about assessing the nutritional status? And we hear that from Tulusi Nayak is asking about, is weight the only parameter that you use?
No. So weight used to be actually the main focus, weight for age, because this is the eligibility criteria for surgery. And actually for many partners, it remains the main focus. The problem with underweight, so of course I presented to you some data with underweight because this is at the time of surgery, and this is a time where partners were not asked to report anything else. I mean, when it comes to anthropometry, than weight. But now we've shifted, and we also try to sensitize partners into considering length and height and assessing wasting and stunting. Because the problem with weight for age is that, well, if you are in a high-income country where there is 0 stunting, well, that's not a problem to use weight for age, because it's automatically because the child is thin, but it has the right length. The problem is we are talking about countries where sometimes 40% of the children without a cleft are stunted. So we really need to consider stunting and wasting. So basically, because weight for age is a composite index between weight for length and length for age, it's not telling the whole story. And yes, we want partners to think about measuring or identifying wasting and identifying stunting. Now, I also want to point to the fact that weight for age remain one of the criteria for surgery. And as you could see, 30% of the children between 2008 and 2018, they were operated, and they were having a low weight for their age. The problem now comes with what this low weight for age means. And in many cases, the low weight is attributable to stunting, not wasting. Of course, there is wasting as well, but this is a smaller contribution to this low weight for age. So we want the partners to be able to identify wasting and stunting, because the management for these 2 malnutrition type is different, in particular because wasting is amenable to a quick rehabilitation. Again, if the partners has the knowledge, has the resources to rehabilitate those children, or can refer them to nutrition programs. But for stunting, this is a much more complicated situation, because the catch-up with growth.
Magic, it's magic. You have supporters. Keep going, please.
So because I just I don't remember even what I was trying to the point I was trying to make. It's just.
Well, this is still very helpful, I think, Barbara, just to jump in. I mean,
but again, basically what I'm saying is now, okay, the partners, even if they are able to rehabilitate wasting, they are faced with children who are underweight because of stunting. And, they might support the nutrition for these children. These children may be catching up with their growth, but, they might never recover the deficit in length and height. So they may always be underweight, even if, so I think that's why there should be also some room for the practitioners, and I am not, a medical person, to actually see with the team whether the nutritional status of the child is acceptable, although yes, he might be underweight, but this is something between, okay, do we delay surgery and maybe risk to place the child in, at risk of more malnutrition, or we go ahead with surgery. Anyway,
Very good. Thank
you. It was a long answer.
No, it's really helpful. And I think also, we recognize English is not everyone's first language. So I think even just this graphic explaining the technical term wasting and stunting and the implication is very helpful. So thank you to the Smile Train New York team also for jumping in. Maybe we'll stop sharing that for a second. And I see a few other questions coming in that are really about this. But before we jump in a little bit further, I think it's really important that you put the context not just in weight for height as a barrier to safe surgery, but I think you're putting nutrition as for every life outcome for these cleft patients. They're more at risk of experiencing malnutrition, and then wasting and stunting is something that beyond just delay of surgery, but also in life development is something that you're saying is critical for cleft practitioners to keep in mind.
Yes, absolutely. Yes.
Thank you. So another question from Malawi, from Tulasi, she's asking both about stigma, but the second thing is, if we're getting into this number one of your 4 principles is effective identification and referral, what about this idea of checking in on the mother's nutrition as a way of identifying, will this child be at risk of wasting and stunting?
Well, yes. I think some cleft partners already do that. They check on the child first, and then they look at the mother, especially because the mother needs to breastfeed that baby. And again, it's not just about, as I said, trying to correct a malnutrition situation, but trying to prevent malnutrition to occur in the first place. So yes, definitely. I don't, this is something that definitely some partners are already doing.
Right, so it's a lead.
But we are not collecting data specifically on that. So I don't know, Sure. I just know by the fact that I've talked to partners, especially in Africa.
So it sounds like that is a good lead, at least a hint to follow if this family might be appropriate for identification and referral. The mother's nutritional status is very indicative potentially of a child that would struggle in this area.
Yeah, but okay, there is something about stunting. Stunting, it's not something that happens in one day. This is something that goes through generations. So a mother who is stunted, she is likely to have a baby who even at birth is already stunted, right? So imagine, this is not just, we are here at the time, we try to be here at the time of birth, and this is already complicated. But in fact, this is not something, this stunting is not a problem, that can be solved very easily. And that is why I said it's very important to identify stunting and wasting, but we can't lose focus on weight for age because of the stunting that is present, coexisting in communities and for generation and generation again, because I think in many countries, with India, I think it's something like 30% or 40% of children who are stunted, children without a cleft who are stunted. So, and these children, yes, they are more likely to have babies who are stunted, even if they feed well during their life, So.
That's great. Thank you very much, Barbara. We'll circle back for another technical question in a second, but Ahmed, you've got your hand up, please. What's your question?
Yes, hi. Thank you. Thank you for the excellent presentation. I just wanted to ask a question. So just a little bit about my background. I'm a final year medical student, and I've been doing research into making 3D printed nutritional equipment for patients with cleft lip and palate. And we started working on a patient-specific bottle, so like a 3D printing, a one-way valve, etc. But I wanted to explore a little bit more. I wanted to see if maybe 3D printing a breast pump and a palate obturator or some sort of feeding appliance. And I wanted to get your opinion on what would you say is the best sort of package for a child? Would it be a breast pumped milk that's fed through a specific, a specialized bottle, or if you have any experience with something like a pallet obturator, if you can.
Thanks, Amit. That's a great start.
Yeah.
So technological innovations, Barbara. Do you have any comments?
Absolutely incompetent to answer this question. I don't know if Pamela has anything to, as you know, heard from
Barbara. You're not incompetent. I don't. You know, the thing is, when you were traveling, visiting our partners in East Africa and West Africa last year, I'm not sure if you saw that use very often. But again, I can talk about the experience I hear about for partners in the Americas, where there's a little bit more experience in providing pre-surgical infant orthopedics and obturators that help with feeding. We do have some pilot work around exploring 3D tools to create pre-surgical infant orthopedics, not only for assisting the preparation of surgery, but also for feeding. It's just tricky because the direct printing of the actual obturator, there's a lot of, I think some of the material is still a little harsh for the children's mouth. I think it's like their delicate gums. That's what I've heard. It's still like early, and there's still maybe a space for more innovation around the actual printed material and whether or not that it's suitable for infants. But I mean, it's a brilliant idea, and I applaud you. And I think that you should keep going with that type of pursuit. I mean, I think that's the way to open up access, so more partners, more cleft teams around the world have the ability to provide that for their patients. So that's as far as the obturator. For 3D printed breast pumps, that sounds a little complicated, but I think, again, like, let's bring innovation to the space. It's so needed and necessary. Maybe before we even get to the breast pump is where something like the Nifty Cup, like this type of a very durable silicone that is very easy to clean. It doesn't have as many grooves, so that especially in places where clean water is an issue, it's easy for the mothers to be able to clean it and then facilitate the feeding of the baby. Maybe that's a more practical first step. But you know, again, I don't want to hold back your innovation and the possibility of technology. I think this is an area that we all really need to put our minds around because there's such need.
That's excellent. Thanks, Amit. Thanks, Pam. Another comment, Barbara, was around this. Someone's noted around diarrhea, and is there any interaction between that sort of interplay with cleft patients? Was a question from Malawi.
What's exactly the question?
Let me know why most cleft patients, or not Malawi, pardon me, that's K-Nut. Let me know why most cleft patients are having diarrhea. Is that something you've noticed?
No, I don't have any data on that. But again, I mean, if these children are less likely to be breastfed, they are more likely to not be fed what they should be fed, breast milk, and they are more likely to experience diarrhea also because, like Pamela mentioned, the problem with MS is the fact that, you know, the mother needs to have the possibility to clean, the understanding, and so this is not something that, you know, can, you know, be. I mean, this is the reason why actually we have so much a higher risk of death associated with, you know,
thank you,
lack of breastfeeding. So.
Mm-hmm.
So
Great.
go ahead. I'm sorry, just one other thing. That's not only the feeding tools that maybe that they're not necessarily clean, whether they're receiving breast milk or formula, but also I think in some of our data from our partners is that because the babies, it's expensive to have formula. If the mother loses their breast milk, they go to formula, but then they start and introduce foods more earlier than what maybe the baby's ready, and that can cause some diarrhea. And if these babies also have ear infections from the cleft palate, that can cause them to have different infections and illnesses. So that can also be showing up as diarrhea. So that's where, again, just early care is just so important. But we don't have a tremendous amount of data on that, like Barbara mentioned, just more anecdotal stories.
And we can understand why a family would be desperate, right? If the child is not able to suck, as we heard from Barbara off the beginning, if there's all these challenges, I mean, they're looking for any solution to be able to let their baby gain weight and to grow. So thank you. That's a great point to bring up. Dr. Siddhartha from Calcutta asking about, and this is not necessarily just for Barbara, but for the group, you know, what about this idea of admitting patients, admitting babies who are not thriving or not responding well to the patient nutrition program. Do you have any thoughts on that to be able to administer parental nutrition or maybe an NG tube, etc.? So I'll start off with you, Barbara, but if anyone else has any comments on this idea of admitting patients who are not responsive to a nutrition program.
I mean, I suppose that also depends on the age of the child. I mean, again, like Pamela said, I mean, my main interactions is with partners in Africa, and I don't think that many use NG tubes, except maybe in desperate situations. But I don't think that this is even something that is used even post-surgery, for example. So no, I think that I mean, I don't know about that really. No.
Thank you. No,
Pamela, maybe.
I've seen a lot of it in the field, but a lot of it they were being used because of ignorance on how, like, there was an understanding on how to feed the baby, so it was just kind of a first stop gate, and that's, it's really sad because there are techniques that that to try and attempt to do, but when the baby is severely malnourished, I'm sure many of you I've heard stories or known children, admitting them and their mother and the caregiver to the hospital is a reality, and that's something that is something that's part of our grant programs that we also cover, because we understand it's not something that our partners can afford. Really, it's something that becomes very, very expensive. But if we're committed to making sure these children thrive and thrive, not only survive, we have to be willing to pay for that.
Thank you. And Pam, I guess, again, we're going back to this key point that this is not just about delaying surgery. If you have these severe cases, this is not just about, come back on your surgery date. This is about the ability of this child to make progress, to thrive, the family to survive, really, in that sense. So I appreciate both Smeltrain and Barbara, your perspective, the wider perspective on this topic. Dr. Christian, go jump in, Barbara, please.
No, I just wanted to say, I mean, there are many partners who automatically admit a mother and baby when they present, just to spend time talking to the mother and explaining to the mother how to care for a baby, just because they know that if they let her go, she will not come back, or the baby will die. So definitely, as Pamela said, some hospitalization, admission, it's something that is actually not uncommon, even in cases that are not associated with malnutrition, but just to prevent the malnutrition to occur.
So if we're looking at the good practice is finding some context to establish that relationship with the parents, the family, to understand what's happening, what are the good, then there's different strategies that people are using. Obviously, ideally, if that identification and referral happens early and is effective, right, things like admission hopefully is not required except in these exceptional cases. But very, very helpful. Thank you. Dr. Christian Murthy, I see your hands up, and then Jasna, I see your hands up next.
Yeah, so I had a question before that. I'll make a comment on that admission issue. We have a very simple formula. There is the Indian Academy of Pediatrics, a classification of malnutrition. It's very simple. If you are 80% or above of your expected weight for that age, you are properly nourished. If you're 71 to 80% of the expected weight, it's grade 1. If 61 to 70% is grade 2, and 51 to 60 is grade 3. And if you're less than half, 50% of expected weight for that age, you're grade 4 malnutrition. And the simple rule is anybody has a grade 4 malnutrition, we straight away admit them. Whatever may be the reason, whether it's inability to feed or some other systemic issue. And most of the times it's the mother's ignorance of technique of feeding, and all we need to do is to show her how to feed. It may be a orogastric or nasogastric tube to start off with. Once the weight gain is initiated, mother is comfortable, we discharge them. This happens at least 2 to 3 times in a year in our unit.
Thank you. That's a helpful specific example, Dr. Christian Murthy. Thank you. Jasna. Oh, sorry, you have a comment? Well, we'll come back to you, Christian. We'll hear from Jasna first. Yeah.
Yes. Can you hear me?
We can. Thank you.
Yes. Good evening here. I'm assuming it's good morning and good afternoon elsewhere. So my question, yes, a very nice presentation, first of all. My question is, for the first 6 months, let's say, would you think the role of, assuming that we all agree, as your presentation suggested, that breast milk is far superior for a lot of reasons compared to breast milk substitutes, and we should encourage, whether different techniques of breastfeeding, whether hand expression or using a pump or whatever other techniques or methods you want to use, you would try to breastfeed the child. Yes?
Yes.
In that case, even regular breastfeeding is some people find it hard. And in a cleft child, you have enumerated all the challenges. Yes. So what do you think would be the role, maybe for the first 6 months, more than or along with the nutritionist, a lactation consultant? For example, drying up of the breast milk is a common problem with anybody who expresses, even for non-cleft children. So you have to tell these mothers, like, just popping a child on your breast is very different from you expressing it with hand or using a pump. So you need to teach them how the expression has to be done, how often, how to keep your supply up, how to store the milk, at what temperatures, how do you clean the utensils. So it's a whole lot of, it's not as simple as we tell, just express it and feed it. There's so much more going on. So don't you think a lactation consultant for anybody who even attempts to express and feed a cleft child is more important possibly in the first 6 months than anybody else? If at all we want to go the breastfeeding route, which is what we would all like ideally before we move to breast milk substitutes of any kind.
Thank you.
Very long-winded question. No,
that's great, Jasna. And just so we know, where are you calling in from, Jasna?
Oh, I'm sorry. I'm calling from India.
India. Okay, great. Thank you.
Yes.
Barbara, please. There's a bunch of things to talk about there, but start, please.
Well, I mean, sincerely, the definition of a nutritionist or a nutrition specialist or lactation specialist is different from one setting to another. So, I mean, what I mentioned with the nutrition curriculum that we have is actually covering every challenge that you've mentioned. It's about talking about breastfeeding and the importance of breastfeeding, but also about expressing, about storing, and about how many times you should feed the baby, what you should expect, what kind of volume you should expect for the baby, etc., etc. So it's I would say, like 50% of the training content is about feeding infants and about techniques and about potential tools, and about how to wash even, and how to, even when commercial BMS is not affordable, even for the partner to support the family, how to modify cow's milk. So I mean, I agree with you. I know that even for mothers of infants without a cleft, it's a challenge. But when it comes to the mothers of those children with a cleft, I think we have it covered, at least in the training. Because most of the partners, at least those I've interacted with, they don't have a nutritionist, or they have a nutritionist who has never managed children with cleft. They don't have lactation, consultant, or I've never, not in Africa, I've never heard of that. No, I've heard of nurses having some nutrition background and nutritionists and dietitian, but not even lactation specialists per se. But really, I think when we use this curriculum, this is how we are trying to train people to become lactation specialists. Or
that's great.
And if I could just jump in really. Oh.
Yes, I'm just using the term.
Oh, I think we've lost you, but Jasna, that's fine. Yes, I think we understand the idea that a formal lactation consultant is probably unlikely in many of the cases as context we're there.
Yes.
But Pam, jump in, please.
I just want to say that, from a global perspective, I think, for Smile Train, and I'm sure many of the other organizations that are represented on the call, as we really try and advocate for cleft children, for their the importance of their nutritional status, for the challenges that they experience, we have to be able to talk the talk and walk the walk in the global nutrition space. And in order to do that, and also we obviously our foremost concern is the health of the mother and the child, right? And so in line with that, we have to advocate for breastfeeding for these children, right? That's first and foremost. But we understand very really that it's not the reality for many of our families, as Dr. Krishnamurthy mentioned. So also in this advocacy space, we are being upfront about that, and how, yes, this is what we're making sure that the nutrition specialists who are on the ground with our partner sites have that information and that training around breastfeeding and all the different ways to do it, and whether it's stressing or direct feeding. But if all that fails, we have to be realistic that our partners also have the resources and the tools to provide guidance for breast milk substitutes, or even adapt cow's milk in a desperate situation. And we're being upfront about that. And it's honestly, in the global nutrition space, it's really hard. And it's a dance, because we have to make sure that our children are not left behind, and that we advocate for cleft, lip, and palate, but also at the same time that we're respected, for the work that all of us are doing in cleft, because it's not always possible to do breast milk. There's a lot of global regulation around it too. So anyway,
Thanks,
I think that's
important.
important.
And I think that's important just to name off the top, right, is that the WHO guidelines, as Barbara mentioned, even up to 2 years, breast milk is primary in all this. And yet we know that the patients that we're focused on have distinct challenges, without diminishing that message, saying that there has to be accommodation, because the alternative, as we've heard, wasting, stunting, life limit, delayed surgery, all these other things that we're so concerned about. Our time has flown, so thank you very much. We'll just need to, if we can switch back to just the end of our slide. Barbara, this has been fascinating. Obviously, you've opened up a really rich discussion that especially is of import during this time where we know families are facing increased insecurity. If you have colleagues who you think would really benefit from this and who missed this morning, we will be posting this a little bit later onto our YouTube channel. You can invite people to view that. Pam has already suggested she'll post some things in the Circle of Cleft Professionals Slack channel, some different resources that are there. We want to learn from one another. As Pam mentioned, we have lots of different NGOs that are on this call, all with the same understanding, wanting to support patients, families with cleft to make a full recovery. That's the essence of comprehensive cleft care. And we're so delighted to have experts like Barbara this morning sharing from their expertise of how nutrition really is a foundation for effective cleft care for the long term. So thank you very much to everyone. Niti, what else do we have here?
Sure. Thank you so much, Barbara and Pam. So we have our own CoCP YouTube channel where you can access all of our previous webinars, including this one, as you mentioned, which will be posted soon. We've also created some playlists that you might find helpful. Most recently, we've created one for speech therapists, since we've had quite a few CoCP webinars on this. So go ahead and subscribe to our channel, Circle of Cleft Professionals, to have access to these playlists and immediate access to any videos that we post. We'll also share the speech therapy playlist link on chat here. There, I've shared that. And yes, and a big announcement. We have the date of our second ESPA CCC virtual conference titled Solutions for CCC, COVID and Beyond. It's going to take place on the 2nd of June and will begin at the same time as this webinar at 8 a.m. EST. Just like the first one, our conference this year will run for 4 hours and will be hosted on CoChat. But we promise that there are innovations in terms of both conference format as well as content. We already have solutions groups who are right now in the midst of preparing for this conference. To participate in this conference on the 2nd of June, you would need to apply. It's a really short application form that you can find on our conference website, solutionsforccc.com. We'll also share this application link on the Zoom chat here. Back to you, Hugh.
Thank you. Great. Well, thank you very much, everyone. We do have another Smile Train partner, Dr. Melissa Antonelli from Santo Niño in Sao Paulo, who's going to talk a little bit more about speech therapy coming up in June. So you won't want to miss that. And again, thank you for joining us. We recognize that in most of the context in which we work, having specific experts on all these topics is very difficult. So that sense of knowing, understanding, and really building upon some of the insights of a nutrition specialist is critical. And we saw that as the number 4 in Smile Train's training, that sense of your team being up to date, having these discussions, knowing that they will have to build relationships with the families in order to combat stigma, malnutrition, poor understanding of the challenges is critical to be able to see everyone move forward. So anyway, thank you everyone today. We've come to the end of our hour. Please stick around and type any chats or anything else you want, but we're really delighted, Barbara, that you joined us today, and thank you to Smile Train.